I am Valentin Fuster from New York, and I am the editor of the Journal of the American College of Cardiology. And actually, we are going to say that this is sponsored by the American College, and I'm very happy to be talking to our South American friends with a fantastic panel of speakers today. And I would like to have the opportunity to introduce them. Let me introduce first Dr. Gláucia Maria Moraes de Oliveira. And she told me ahead of time that the name is Gláucia. That's the way we are going to ask you questions. And she's professor of cardiology at the Federal University of Rio de Janeiro in Brazil. Then we have Dr. Edgardo Escobar, professor of medicine at the University of Chile, and a very good friend of ours. And I'm very happy you are here with us, Edgardo.
Thank you very much. Thank you for your invitation.
You look a little bit serious, though. All right. All right. So let's then move. Juan Granada. Juan Granada is the president and chief executive officer of the Cardiovascular Research Foundation in New York. Welcome, Juan.
Thank you for the invitation.
And then finally, and not the least, Dr. Daniel Piñeiro, professor of medicine at the University of Buenos Aires in Argentina, and upcoming president of the World Heart Federation. But let's not to be shy because he's going to be the president of the World Heart Federation.
Thank you.
We are all the same here, okay, my friend? So
yes.
let's go on. Look, they gave me a title, and let me see if I find the title here from this symposium and questions and answers to transform cardiovascular care and improve heart health. Amigos míos, podemos hablar en español, podemos hablar en portugués, pero me han prohibido que lo haga. Me han dicho que lo tenemos que hacer en inglés. No conozco el background, por qué, pero me voy simplemente, yo trabajo por el American College of Cardiology y tengo que seguir sus instrucciones. O sea que vamos a volver al inglés. Well, welcome to all of you. This subject to transform cardiovascular care and improve heart health is a very, how can I say, is a very broad topic, but I'm going to go step by step into what I consider an important issues to be discussed by the experts here. And for example, let me begin with you, Daniel. Cardiovascular disease, we are tired to say is the #1 killer today. I hope someday we can say it's the second or the third or the fourth. But anyway, the thing that worries me is when you look at the trends at the present time in terms of cardiovascular disease and mortality, is beginning to increase again. And this is not related that people is getting older, and is not related by the number of people who are born. This is very well. Is related to something else. What is this something else, Daniel? What do you think?
First of all, thank you, Valentin, for the invitation. From our point of view, from the World Heart Federation, we think that this is a social. This is you know the determinants of health and disease are especially social and economical issues, and there are many changes around the world that makes people to go to a more syndemic scenario. Let's say cardiovascular disease is jointly with other disease, but it's the first cause of mortality around the world, as you said.
But why is increasing such mortality? That's my question to you.
Because the common risk factors, smoking, the kind of foods we are eating, the obesity is a big problem, low exercise, but also new determinants as pollution is very important. Climate changes is important too. So we are paying attention of all that. you know that now pollution appears as a very important issue in this scenario.
Well, thank you very much. Let me focus on diabetes. Gláucia, what do you think about obesity and diabetes? Because it appears they are in the forefront of a real epidemic at this time. And why is this happening now and not before? What do you think the reasons are?
I think that, first of all, thank you for the invitation. It's an honor and a privilege to be here. I think that in my country, for example, I have increased BMI very, very high in young people. And then you have obesity, you have lower exercise, and with that, we have more diabetes. And diabetes in my country is increasing in women more than men. So I think that it's a joint factors that is growing up to make people with more diabetes, obesity, and low exercise, and so on to increase diabetes.
Thank you very much, Edgardo.
Yes, let me say something about diabetes.
Go ahead.
Because in Chile has been a big problem, and interestingly enough, the Ministry of Health has surveyed the adult population, and there was one in 2009 or 2007, and the prevalence of diabetes was 4 or 5%. And now, in the last survey performed 2 years ago, it went up to 9 to 10%. So something is happening that is very bad, because it doubled the prevalence of diabetes in the general population. So it's a very important problem.
Edgardo, let me go back to you, because this problem of increased cardiovascular disease and actually mortality, which is now in the plateau going up, certainly obesity and diabetes are really key factors. Why? What do you think is leading this world to be more obese, and as a consequence, more diabetic, since 75% of type 2 diabetes comes from obesity? So,
well, I think it's you have to actually remember that what Daniel said before, the people is getting more sedentary. Our sedentary rate, at least in Chile, is 70%. 70%. Obesity and overweight is 60%. Chile, you know, is a very long and narrow country, but we are very fat because 60% of the population has overweight, is overweight, or has obesity. So the dietary habits of the population has changed, and maybe there one of the factors is the factories that they have this very bad foods with a lot of calories and a lot of fat, and the people like that, unfortunately enough, in spite of all the educational programs we have. So there are several factors that are combined to get these very bad results.
well, Juan, you intervene at coronary arteries, and you love to do that. Certainly, this is very late, and I have seen you talking about saying, you know, now we are going to do more medical therapy and so forth. When we talk about medical therapy, we are talking more statins, more aspirin, which I agree completely. But how can we change behavior? You know, obesity is not a drug that we can give and so forth. Smoking, lack of exercise, which is what Edgardo is saying, and Daniel already pointed this out. So what can we do? It's not a matter that less PCIs and more pharmacological therapy. I think it goes beyond all of that.
You know, first of all, thank you for the invitation. And you're absolutely right. As a plumber representing the interventional community, angioplasty is not the answer to the big problem that actually we have. Our field has become very reactive, and that level of reaction is related to multiple social, political, and actually financial incentives. And one of the issues is the gap, the equity gap is increasing in countries, for example, like Colombia, in which it's easier to get access to cigarettes and bad food than actually, healthy food and lifestyle modification. Also, we have a big percentage of population that actually live out of the big cities, and they don't really have access to primary care. So when the patient shows up, the first encounter with medicine is actually a stroke or a heart attack. So one of the things is, Dr. Fuster, you've been saying this your entire life, and we need to go early. And there is no any other way that actually going aggressively and intervene with cognitive therapy, lifestyle modification, and behavioral therapy, all these bad behavior that actually we have as humans, especially in a society that doesn't really support, healthy lifestyles.
Well, thank you very much. When you talk to go early, Gláucia, I have a question for you, which is, that's true. I have been very obsessed about this, and that is what we learn when we are children in the environment and everything. We capture that, it gets into our brain. Later on, we have so many messages and nothing is captured. And then we believe strongly that if you get into childhood and begin to talk about health and promoting health, I think this can come out when we are adults. Why this has been absolutely ignored in an intelligent society? How is possible that we don't pay attention, that we are dealing too late in a disease, and there is an opportunity, which is when we are aware of what somebody tells us, which is during the childhood? What do you think has happened?
I think that maybe it's because we don't have good food in schools, for example, and not education in CVD disease. Nowadays in Brazil, we have a program that is named SBC vai à Escola. It's Sociedade Brasileira de Cardiologia, Brazilian Society, and you go until the schools and we try to show to children about the CVD disease, how they eat well, how they exercise, and how they can not go obese or obesity, and so on. And we do it in a simple way to try to change it. We don't have any numbers to show the efficacy of it, but the children play with food, play with exercise, and maybe it can change things in Brazil. Also, you have food at school, because most of our school is not private, is public schools, and then you have food for children in schools, and it's good food. And so I think that maybe can change things during her whole life. I don't know.
Well, yeah, go ahead. Sure.
Yes, I believe that education with capital letters is the most important thing to prevent, or not only cardiovascular diseases, but other also. But you have been a champion in this field. But unfortunately enough, at least from my point of view in South America, I don't foresee any project at the level of the Ministry of Education that involves the education of children about health. So we tried to do that, but we have failed. If there is not a recommendation of the ONU, maybe, I don't know, United Nations or the World Health Organization, that actually involves the Ministry of Education of every country to do this, is very difficult to go ahead.
I tend to agree. I think it's beginning, well, you know this program, Sesame Street, which was an educational program that had nothing to do with health. At the moment that Cookie Monster stopped eating cookies 7 days a week and just 1 day a week, had a huge impact on children. And now Sesame is completely focused on education in terms of health. And in fact, I have to tell you that it's going to start in South America, in most of the countries, in the next 3 months. I am involved on that. And that is why, because this is a program that can really attract children from the educational point of view. And it's fascinating how a program that was general without any specific objective, rather than entertainment and maybe education in some aspects, is going actually to be focused into what you are asking. So I think there is some hope there. The question I have, and I like to ask Daniel now, the question that is happening is, these children, we have a lot of experience now, they go home and to spend, 60 hours, which is what we do for the training in the school, 1 hour, every 2 days about health, then they go home and the situation is different. So I think that the question I have for you, Daniel, is the answer is not to create a culture in which the children is part of this culture, but also the parents and the family in growing this up. I'm beginning to feel much more on a culture than on an individual basis, with children perhaps being the main, perhaps, targets. What do you think about this?
I think, Valentin, that we as physicians are good for clinical practice, not very good in basic science, but very bad in implementations. So we don't know how to move in implementation work. So I think we have to start studying deeply in implementation. Implementation is a science, and we are very weak about that. So implementation means that we have to take into account that this is a cultural problem, and we need anthropologists, sociologists, economists, people of other capacities, not only physicians. And I think that education is very important. It's very, very important. Probably is the number one, but the number two is regulation, because as Juan said, in Colombia, it's very easy to smoke because it's very cheap. So, and we know that the most important measure to cut tobacco use is taxing. So my feeling is that we have to move from our spatial scenario of medicine to a broad scenario that is cultural changes. And to make this cultural change, we need education, we need regulations, and we need to study and to be better in implementation science.
Well, let's go into regulations and let's move into guidelines. Gláucia, I have a question for you. I feel guidelines are absolutely primitive, and let me tell you why. They are starting at age 40. And then you say, what are the risk factors at age 40? And we are going to prevent events. And you don't know subclinical diseases starts at age 15. Everybody has data. We have data on imaging, autopsy data, and so forth. And then there is very good information now that if you begin to trace cholesterol levels up and down, or blood pressure at younger age, you can predict what is going to happen later. Tell me why making guidelines means you are absolutely cutting things from age 40 on when you are really missing when the disease is actually evolving. How would you react to that?
I don't know, Professor Fuster. I think that it's a great point, but I don't have the answer. It's a difficult answer. But I think that one problem with the guidelines is that they are very complicated. I think that you need the guidelines more simple, easy to use. Yeah. The way that they put things together is so complicated that if you follow it, you don't go on until the end. So maybe I think that if I can answer to your question is make it simple, to make it applicable, to make it feasible. I think so. I don't know the answer, the correct answer.
Yeah, but anybody has the answer? Why the guidelines?
No, I have not the answer, but I'm sure that the guidelines in the way we are doing that is not very useful now. And I think we have to think that the guidelines from AHA, ACC, ESC only can be used in this higher level income countries. So we have to make new guidelines thinking in real people in our middle and low income countries. And sorry, and the other point I want to add to Gláucia is make it simple, and as you said, we have to feel the urgency to treat people, not to treat with drugs, but to pay attention to people in the very young age, because we are missing all the possibilities of making good things for people in the young age. I think we have to focus in young people, especially in children, but in young people.
Thank you, Daniel. Edgardo?
Yes, I would like to mention an experience we have in Chile about this, because the guidelines are made by the cardiology society, the scientific societies, and we all know that not everybody, not all the doctors there read them or follow them actually. And in Chile, the Ministry of Health, with a combined program with the Chilean Society of Cardiology, has guidelines at the level of the Ministry of Health, and so the guidelines are not of the society, but of the state of Chile. And they are distributed all over the country, mainly to the primary care doctors. And there are another program specifically addressed to the primary care doctors, with very simple instructions how to diagnose and how to treat the patients and how to follow them. So this combination of the Ministry of Health with the society, I think is very important, because the society by themselves are not enough.
I tend to agree with you, or somewhat theoretical. Anyway, I have Juan, you have something to say, and then I have a question for you.
Yeah, one thing that I wanted to say, and it is actually unfortunate to bring this up again, but I really think that the financial incentives of our healthcare systems in general are putting the money in the wrong pathways. One thing that for me is mind-boggling, for example, is the fact that, we still do invasive catheterizations when actually in a great majority of patients, we could do effectively CT scans. And this is actually mainly driven by the financial incentives that actually institutions and healthcare systems actually have. If you actually look at early prevention, you pay very poor salaries to people doing primary prevention, and actually bigger salaries to people that actually do, interventions. So one of the things is, unless, we have real, changes in politics and actual incentives to put the money on the right track, on primary prevention and actually early prevention of disease, it's going to be very challenging to actually change a system that essentially is driven by significant financial incentives in multiple actually areas. Well,
Daniel,
I want to add something to Juan.
Sure.
I agree completely. Primary care is 90% of health is going through primary care, but we have to change also the school of medicine. The school of medicine teaches for acute disease, not for chronic disease, and teach us where we can make money and where not. So we have to strengthen the primary care physician, and we as cardiologists could help them, could say things to them, but we have to support very hard our workforce in primary care.
Okay, let me go back to Juan. I wanted to ask you a question. Let's now leave for a while children, okay? We all are in agreement of the critical issue of education and the culture that you can develop with the families and so forth. But let's go now into middle-aged people, let's say between age, let's say 50 or age 40 and age 65, okay? Let's do that.
Our age.
Well, I don't want to ask your age. You look much younger than that. Anyway, I think the question I have is, what is the challenge? For children, the challenge is education. This is very clear. That middle age, you have been putting catheters inside the arteries and with all the kinds of OCTs and ultrasounds and looking at imaging, because to me at least, is that the main risk factor of arterial disease is to see it. All the rest is statistical. 50% of the smokers have disease, 50% not. But if you see the disease, you can tell. Now, here's the problem, Juan. What you do is what can be done in 1 in 1,000 of the population. That is to put catheters and to see with help. And in general, is already too late when the disease is already advanced. Now, what do you think about the new technologies that are evolving now with external imaging without injecting anything, with 3D ultrasound? I'm not talking about myself, but we have done this in 12,000 people already. And we are learning so much and so cheap and so economic that you can go at that age, and then we'll talk about the impact if you know you have disease or not. But I want to hear from you, since you have been technologically oriented. And I think it's a tremendous opening for the future, I believe, in the issue of imaging.
It hurts me to see that we already have the technology to diagnose, screen, and stratify patients that are high risk at a very early age, and we're not doing it. When I turned 40, I got a CT scan and a CT angio because I have a very strong family history of coronary disease. When I turned 50 last year, I had a second CT angiogram. Because one of the things is knowing is power, and knowing essentially is going to force you to make drastic changes in your lifestyle, even though I live a very healthy lifestyle. But I agree with you that it is a question that for me is really difficult to answer, because the technological advances in ultrasound, in contrast imaging, in non-invasive imaging, right now we could screen millions of patients at a very low cost and being able to put people in tiers according to the risk profile and actually prevent a lot of strokes, a lot of myocardial infarctions, and a lot of actually heart failure in the future. So the time is now. I mean, the technology is ready. What is right now in the pipeline for imaging, non-invasive imaging, is something that I've never seen before.
Okay, Gláucia, what do you think?
I think it's a good idea, but I think that maybe another technology will be more capable to change things. I mean, digital health, for example, not imaging. I am changing for another way. But for me, for example, we have a continental country with more than 5,000 municipalities, and much of them is in rural areas or areas without any health system. So if I can use digital system in my primary care with health family program, we have a family program. Each one of these municipalities has a group of professionals of this family program. If I can put digital health there and teach them, not cardiologists, but maybe nurses and maybe other kind of professionals, maybe I can change things with great impact in the future than imaging technologies.
Yeah, I have a question. Maybe I will ask Edgardo in a moment, but the imaging technology we are talking about, is extremely cheap. In fact, when you use ultrasound in the disease starts in the iliofemoral region, interestingly. the arteries are large, so there are no symptoms. You can do that, and I can tell you in 2 years, I can predict, maybe in 4 years, I can predict that by $15, you will be able to do that, and even less. Just look at the single artery externally and predict, because the disease is systemic. So, and we will go back into the local aspects, because it's very interesting what you said in a moment. But let me ask Edgardo, do you think, we talk about children, education, now we are talking about really non-expensive external imaging, that if you see the disease, this is the highest risk factor. What do you think, Edgardo? Do you agree with that? Or maybe you have other ideas?
I think that is a very useful and important tool to be used. And I could add to the technological field the place that telemedicine could play in this scenario. I think telemedicine is a very important tool when you have countries like ours with extensive rural population. They then don't have access to the medical care, and they have only very, very primitive or very primary care, medical care in their communities. And so a program of telemedicine, I think it could enhance this other technique that you were mentioning. I think we should think in a strong program of telemedicine, especially in countries like ours.
Thank you. Daniel, any comment?
Yeah, my comment is that I think that these very, very, very basic imaging are an extension of physical examination. So when Laennec introduced stethoscope, it was a machine just to hear the heart and so on. But the new generations are going to have an echo in the mobile phone and look for an artery, and it's an extension. Our good friend Jaga Narula wrote a couple of papers about ozonization as the fifth pillar of a physical examination. So I think we have not to think about very complex imaging that are very, very useful. Let's say resonance, let's say CT, but echo is, for me, is going and is now an extension of physical examination. So nobody is going to measure, let's say, blood pressure. And the same is to see an artery and to see if there is a plaque there and to start treating this patient. So I think this is the future.
Yeah, I agree. Ultrasound will be able to see the arteries. Now we use it for the heart, but I think it's going to be much more than that.
It's much more easy to see an artery than to see the heart.
Yeah, yeah. Well, anyway, I think we are talking about what I wanted is to move actually towards the future. But now let me go back to the issues of guidelines for a moment, because that's what people don't read the guidelines. Actually, I tend to agree with you. You know, from time to time and so forth, you can have a debate. But let me discuss blood pressure. It's not correct, Daniel, that blood pressure is the #1 cause of the cardiovascular mortality today. Now, why, as editor of JACC, I see papers every week about whether it's 120 millimeters, or it's 125, or it's 130, and maybe there's, in all the papers is the sprint trial and all of that, but my question is, 50% of the population don't know their blood pressure. And 50% who know it, half of them, they are not treated properly. So are we crazy? What are we doing? Tell me, Daniel, what are we doing?
I think there is a big change there too. That is now we have automatic devices for blood pressure measurement. So for me, the future is to empower people to have a machine and it's not the doctor who is going to measure blood pressure. It's each patient can measure his or her pressure. So I think completely agree. It's completely crazy. In my country, only about 20% of hypertensives are real control. So it's a shame. It's a very shame not to have, because there are some topics, let's say, Chagas disease. Chagas disease is very complex, and we need research about Chagas disease, about treatment, about vaccination, about many things. But hypertension, we can treat 95% of populations very easily with a couple of drugs. So I think, as Gláucia said, we have to make guidelines simpler, to put the feeling of urgency of treat patients and to empower patients to measure the blood pressure.
Great. Let me go to Gláucia. She talked a minute ago about these rural areas where difficult to reach and plunge. Do you think we will be able to measure blood pressure in these areas? It's the #1 killer, so I'm just putting blood pressure as a protagonist of what we could do. What do you think, Gláucia?
I think that it's correctly, but I think that I agree with Daniel, because you have to have regulation. I mean, in Brazil, we have a popular pharmacy, and I gave drugs for free to patients with high blood pressure, but I didn't control it. So our Minister of Health are asking people from the health family program to control blood pressure. If they don't do it, the municipality don't receive the money to treat people. I mean, maybe we have to give drugs to measure the pressure, to treat the high blood pressure, but you have to ask people to control it, to see it, to follow it. The healthcare provider have to go until people are. I think that is the reason that you don't control it, and maybe you can raise the control in Brazil in a period of time, not so long.
Okay. Yeah, go ahead, Juan. Go ahead.
That one thing, Dr. Fuster, I think is key for hypertension is, and I think this is where technology can really make an impact. You know, people go to the physician's office, blood pressure is measured once or twice, patient goes out, and therapy is provided based sometimes in a single measurement. I mean, right now, there are technologies being developed in which, with the use of a single bracelet, you can actually monitor blood pressure almost every 30 minutes in real time in a continuous fashion. And I really think achieving that goal is important, because creating awareness, and the second thing, monitoring, blood pressure changes, over time in a single patient, I really think can be a significant impact. Hypertension is one of these things that everybody knows is important, everybody knows is critical, but is kind of dismissed because it's just a number in a chart. I really think that hypertension needs to be brought as an active condition, as coronary artery disease, something that actually is seen and can be actually treated. And I really think that real-time data is really an important step here, because in that way you can monitor the patient on real time and being able to really make significant changes on the patient.
Edgardo, can I ask you a question?
Yes,
Do you think we will reach all these rural people with what Juan is talking about?
Well, I think we should involve other professionals to the doctor, like nurses, like nutritionists, for instance, to help us for the detection and the treatment control of hypertension, if they measure it well. Because let me tell you that my impression is that the technique to measure the blood pressure is not very well used, actually, according to the guidelines of all the cardiology societies. The cuff is very bad position. They put the stethoscope in places that are not correct, etc. But if we overcome that problem, the help of the nurses and nutritionists and other professionals, I think it would be very important, particularly in rural areas. And if they have the possibility to transmit the information to a medical center through telemedicine, like the cell phone or computer or whatever, I think it will be very helpful to the control and the detection of the hypertension.
Okay.
I think, Valentin, first of all, we have not to use the stethoscope for measure blood pressure. We have to go to the automatic devices.
That's
and
right.
The second point is that we have to make alliance with the community leaders of each rural community, because this is the model that René Favaloro used, let's say, more than 50 years ago, and to implicate the community in this issue. The leaderships of rural communities are very clever, very smart people that can help us very much in these issues. If we convince them that it's important, they will measure, because they are very interested in their populations.
Yeah.
So alliances are very important too.
Now, Juan, we have a project in Kenya, and in a poor part of Kenya, actually, which they keep the food with salt. They don't have freezers. And there's a lot of hypertension. And there was the first time that of projects we have done that we use group therapy. And that is, you put a group together and all have high blood pressure really predominates. And then you are able to convey the importance of blood pressure and all of the things we have been talking about. And the results actually have been fascinatingly positive, with one problem I will tell in a moment. On the other hand, we have projects in which you go individually. I'm not talking about the patient who comes to your office, who you know. I'm talking about globally. To go individually, to try to address risk factors like hypertension or anything is extremely expensive. I can tell you, we have already finished 3 or 4 projects, and we can say anything about individual targeting of risk factors. And again, get out of your office and go in the world is really very difficult. So the point I'm trying to get into you, see what is your opinion. Both types of projects, actually things work over a period of 1 to 2 years, the individual approach and the group therapy approach, with one difference. The group approach was very cheap. The individual approach was very expensive. No question about it. But you know what happened after a year or two? The whole thing goes to baseline. So what we are really learning, and I think it's very important, that we as humans, we don't have sustainability. And therefore, the question is the re-education of people, the reintervention of people. And I'd like to ask you, because, and I think you and I have talked about this before, and that is, let's now go into health, but trying to tell people that we are all humans. And this requires, from time to time, a reinforcement. And the other issue is the culture, the group therapy, rather than individual. And I'd like you to comment about this, because you have been in both fields, in the field of clinical medicine and the field of intervention. I'd like you to comment about it. And I will ask the same questions to all of you about how you change behavior and the issue of sustainability. Juan.
So I would answer this way. If you actually look in digital healthcare, the most successful applications developed to date are the ones that don't tell you what is bad for you, are the ones that actually keep telling you and reminding you about disease state and actually disease conditions. For example, weight loss. If you actually see, there are several applications right now, very interesting applications. The most successful are not the ones that actually restrict calories, are actually the ones that use cognitive therapy.
Yeah.
Keep reminding the patient that actually eating healthy, restricting calories, and actually walking is actually a much better thing than avoiding to eat a burger. So I really think that reinforcement and actually the psychological aspects of human health they are actually as important, if not actually one of the most important aspects of primary prevention.
This is great. I sometimes I see nutritionists that they give a diet to somebody, they don't see this individual anymore. And it's just a joke. Edgardo, give us your views about how we are human beings and how we need this reinforcement that Juan is talking about, sustainability.
Well, that is a very difficult issue, actually, because you have to first to convince the patients or the persons or the people in general of the importance to be diagnosed early in their lives about this type of diseases. And that is a very difficult problem. And you know that human beings, as you say, is a difficult problem to attack. So that is the reason why I believe in something in what the Ministry of Health should be very much involved in order to comply the health system to approach this problem. I couldn't say much more.
I think the Minister of Health has a lot to do with laws for smoking and so forth. But, you know, when we get into obesity and we get into exercise and so forth, I'm not sure the Minister of Health what can do, but I think what I'm really talking about is we need this intervention that is constant. And I believe more in culture and in group therapy. Culture is the environment, in wherever it is. We can be around your church or around your area where you live and so forth. But I'd like to ask Gláucia, what is her view about the issue we are talking about? We as humans are not sustainable. And when we talk about health, it's not different than in many other aspects of our life. And I'd like you to, your opinion, what can we do in terms of health about that?
Professor Fuster, I think that you have to make an alliance with all the stakeholders. I mean, the example is tobacco in Brazil. I think that you have a good work decreasing tobacco consuming in Brazil. So to do that, we made an alliance with all the actors, the health minister, the cardiologists, the pulmonologists, the media, the industry, and then you raise the consumption of tobacco in Brazil. On the other hand, we are seeing now young people consuming more alcohol. And then you have to have another alliance with all actors to change it. And our tobacco decrease in tobacco consuming in Brazil is sustainable. You can see it. We can follow it with the statistics. We have a GBD group that with research of all areas of Brazil, and we are following it. And then we are, it's the same, almost the same. A little increase of 0.4%, but always the same. I think that is the answer is analyze of all the actors.
Very interesting, Daniel.
Yeah, I think that.
Let me ask, because I want to follow. Gláucia says something very, very important. I always felt skeptical about in the year 2030, we are going to decrease by 50,000 the smoker. I don't know. All these things that the organization, look, I have been in the American Heart and I have been in the World Heart Federation, so I cannot exclude myself from these organizations. But to me, it's a joke. Why? Because after tobacco is alcohol. After alcohol are other drugs and so forth. So I think we have a mission here, which is you cannot just say we are going to achieve this because you leave the other things around. Look, pollution. I think you are the one who mentioned pollution. Is not correct?
Yeah.
Well, what can we do? So everything, we have one thing after the other. So the question that I'm asking you, can we convey a culture of health rather than talking about disease? Can we convey from the beginning, and rather than giving dates and all of that, to be obsessive about can we make the population healthy starting from the very beginning of life?
Art, just for my role. I think that we have to take in account things that are happening now let's say tobacco, let's say alcohol. I was thinking about to highlight the importance of patient organizations. You know that patient organizations are now part of the World Health Federation as federation and foundations and societies. So patient organization, the role of community is very important. The other thing is much more philosophical. It's just to create a new world, because you know, with, let's say in my country, 50% of population is in poverty. So it's very, very difficult to say people, you have to take care of your food, no smoke, not to drink alcohol, and say, but I'm in the poverty. I have no way to live tomorrow. So you are telling me what's going to go on 10 years, and my problem is tomorrow, not in 10 years. So I think we have to create this atmosphere of a little more healthy world. And in that case, the involvement is not only for physicians, not only for the Minister of Health, it's from the Minister of Economy, the Minister of Agriculture, the Minister of everything has something to do with health. So it's a big problem. It's not a problem for physicians. It's a problem for the society. And we have to afford that and to say to the big leaders, we are in a very, very hard problem, because new generations are going to live less than last generation. And this is a shame for us as a civilization, but it's a philosophical question.
Yes, Edgardo, what do you think about health versus disease?
You ask me?
I am asking you. No, but
I would like to comment before that in Chile we have two important initiatives about healthcare. One is the labeling of foods. So foods are labeled with a sign of alarm when they have too much salt, too many calories, and too much fat. So the people knows that they are buying food, healthy or bad food anyway. And that, I think, has helped. Another thing that has been done here is the labeling of the pack of cigarettes, and they have very awful images of the consequence of tobacco consuming. People with cancer of the lungs, of cancer of the tongue. So the people who is smoking knows that they are facing that danger. But in spite of that, the percentage of people who smokes here is about the same. And very sad to say that the young people is getting more smokers than before, in spite of the campaign. So I think it's a very tough problem. That's the reason why I believe in the education of the young people at the school level. If not, it's almost impossible to achieve the goals that we are looking for.
So, in fact, we talk about the importance of education at a very young age. We talk about the role that imaging may evolve at middle age in a very economic way to make people to know they have disease and they have to act about it. And we talk about the guidelines. We talk about difficulties, like we are crazy. We talk about blood pressure with numbers constantly without realizing people are not measuring the blood pressure. But I'd like to turn finally into one issue, and is the elderly, if I may. Now, there is more and more data, actually is evolving so rapidly, that the same risk factors that affect the large arteries are affecting the tiny arteries of the brain. And in fact, the data is becoming so overwhelming now, like degenerative brain disease, the people with cognitive dysfunction, and even acceleration of Alzheimer's, there's a tremendous role for the risk factors that we are just been talking about. I had a patient yesterday, and you had these patients constantly. Doctor, why you bother me with the smoking cessation, weight reduction, and so forth? I prefer to die suddenly, they believe, of a heart attack, and then you bother me. This is very common. We see this all the time. Now, what about if we tell our patients, what about your brain? You might not die of a heart attack, but what about if you begin not to recognize the people you love and you even don't recognize the names? And I will tell you, in our experience, because we have been in this field of the brain very recently, this has a tremendous impact when you talk to the patients about the brain rather than the heart. So the last point I wanted to get into is the elderly and his brain function. And to me, is a tremendous tool that may evolve in us as cardiologists to get our people to begin to listen to us about tobacco and all of these things. And I'd like you to comment about, actually, I'd like to comment about this, all of you, and that is about aging and what we could do in this regard. Again, it's starting at young age, of course, but I'd like to hear from you. Edgardo, you are first.
Okay, well, I agree with you that the message to the patients may be more important if you talk about the brain. I tell my patients, if you die suddenly, actually, it will be wonderful. I would like to die suddenly and hopefully when I am sleeping. But unfortunately enough, that is not the frequent way to die. And if you are hypertensive, you are facing the possibility to stay for life in a chair with your half of your body without any movement or difficulties to talk or whatever. And that impressed more the patient than to die of a heart attack. So you are absolutely right about the message.
Thank you, Juan.
This reminds me of an anecdote when you were talking, Dr. Fuster, at the early stages of TAVR, when the studies were planned, the initial primary endpoints were related to cardiovascular mortality. And very soon, actually, trial is realized that when they were asking patients about risks during TAVR implantation, the number one determinant of accepting or not the procedure was the possibility of getting a stroke. And actually death was actually 3 or 4 in the list. And the patients were more concerned about disability, and they were more concerned about getting a stroke from a procedure than actually dying from the procedure. So this is actually real. And it's absolutely something that is a very growing problem in our society.
Thank you, Gláucia.
I think that maybe I usually talk to my patients about to die, how to die. And I think that is easy to die, like as Juan said, to die when you are sleeping, but it's not reality. So I always talk about the quality of life, the quality of the rest of life that they have. And I talk to them that if they don't take care of not CVD risk factors, but the risk factors, they will die in a bed, and they will have other people taking care of them. And so it's very important to take care of himself, to have quality of the rest of life that they have. And usually it's work, not so much, but a little, at least a little, they change the lifestyle a little.
Thank you. Daniel?
I think we have a personal approach and a global approach. In the personal approach, I agree with Gláucia and Juan that I used to say my patients, everybody's going to die, but it's not good to die with a stroke or dementia. This is the personal approach. But I think there is another approach that is much social and global, that is the discrimination about age in our society. So I make an exercise with my students in the university about how much is the cost to treat heart failure, and if they can afford that with the payment for retirement, and they cannot. So I think we have to think about that aged people deserve respect, deserve to be secure, deserve to be covered by the health system. I think this society, especially in our low and middle income countries, are not very good places to be aged. So I think there is a personal approach as physician in our office, but it is another as people in the real world.
I appreciate very much your comments about aging and how society views aging. It's like you are not useful anymore. Yeah. And somehow this is a terrible. We could spend time on this, but I just like to finish by asking each of you of the issues of health and disease, what would be your recommendation to society, and I say in the global way? I don't know, I don't want to talk about governments or anything. What would be your recommendation to society to really move into more healthy lives and to decrease this going up again, cardiovascular disease and mortality? What would be just one single comment from each of you? What this comment would be? Juan, you're first.
Oh boy. That's a tough one, Dr. Fuster. I would actually say that awareness and education is key. I mean, the thing is, you know, even our, you know, people actually leading important organizations that can really make a change don't really understand the implications of simple things. So I really think we need to start by, you know, educating and creating awareness. I think it's difficult to change a behavior when you don't actually see what certain behavior is actually doing in you. So I really think that's key.
Thank you. Gláucia?
I agree with him. I think that we have to invest money in education. And I think that the education in the young people, the children and the adolescents and so on, because they may change things, may change his family, may change his community. And so I think that you have to put money, not only education, but put money for education of these children and adolescents.
Thank you. Edgardo?
If I could make it, I could communicate to the general population something like this. If you want to live longer, and if you want to link better, please follow the recommendations of a healthy way of life. For instance, the famous Simple 7 of the American Heart Association. A simple message to the general population.
What you are saying is you turn your brain on or off. Either you decide to take care of yourself or you don't. I think it's a critical issue, actually, what you're saying. I agree. Thank you. Daniel?
I think we have to pay attention to equality. We have to pay attention to a better implementation of our knowledge. We have to use and to take advantage of innovation and technology. And finally, we have to put health in the center of the political issues. That's all.
Okay, thank you. So we heard education, and then we had you have to turn your brain into whether you want to change or not, and it's simple if you want to do it. And finally, I think with you, what you are saying, Daniel, the word is health. It's interesting. I was in an airport in LaGuardia actually 8 years ago, and I had to name a foundation that I wanted to develop in health. And I said, what name? And I had a deadline of 1 hour. I had absolute pressure. And I sat down and said, what are the 3 most important things in life? And I began to think, and I say, science is important. We really have to understand it. Education is critical, and health, absolutely. So the name came as SHE, and this is my foundation, SHE. And then what happened is I said, in fact, we're not taking good care of women in the cardiovascular field. So I felt so fulfilled by just putting my brain into it in 5 minutes. And this is science, health, and education. And that's really what we are really talking about here. Well, look, we talk about young people, middle age, imaging. We talk about guidelines, the issue of the elderly, the quality of life. I really think this was very, very nice of you to really contribute to this, sharing your views. And now I want to say something in Spanish. That is, even Gláucia understands it, because yes. Portuguese and Spanish and Catalan really are not too different. Os quiero dar las gracias, de verdad. Me siento yo como vosotros. España, lo mismo que Sudamérica. Es decir, que me siento muy orgulloso de poder estar con vosotros hoy, haber tenido esta conversación. Ha sido en una lengua que no es la nuestra, pero bueno, sigo guidelines del American College, pero la realidad está que os aprecio mucho lo que habéis hecho y espero que la gente que tenga la oportunidad de escucharnos, yo creo que ha sido muy genuino la conversación que hemos tenido, hemos expresado cada uno de nosotros nuestros puntos de vista y la verdad es que resumiendo todo lo que he oído, no puedo desechar ninguno de los comentarios que se han hecho. Los veo que todos están en línea realmente en el tema que nos incumbe, que es el tema de la salud. Bueno, muchísimas gracias a todos. También daré gracias al American College, aunque no saben lo que estoy diciendo. Por estar todos aquí. Y hasta muy pronto. Y os agradezco mucho que hayáis aceptado la participación. Muchísimas gracias.
Gracias a ti, Valentín. Buenas tardes.
Valentín, un gusto.
A vosotros. Adiós, gracias.
Gláucia.
Adiós, adiós.
Obrigada.
Obrigado.
Thank you.